We have got the Jenny Shand, hot takes, let's go.
So my bugbear is that people talk about equity as an additional cost. And what we need to be thinking about is what value can it generate? So if we are accessing those missing populations, how can we get value for them with better access, better participation, and ultimately better health outcomes?
And when you say value, are you talking about returns for investment? Because a lot of people are focused on financial returns. You said something really great earlier about how we think more broadly. Can you talk about that?
So traditionally, the value equation is outcomes achieved per pound spent. But what we need to do with equity is be really honest about the cost of missing those populations. So we need to add an additional layer into our value equation that takes into account what does it cost to design, build and implement for equity, and what additional value do we get from doing so, which is that additional outputs and outcomes for those missed populations.
And do you think in this world where growth at all costs is kind of the predominant gravitational force that's driving everything forward, do you think there's room for this? For people who care, are they still going to be able to win in this market?
I think equity is a moral obligation and people are really clear about that. Yes, cash releasing savings are a priority for our system. Yes, money matters. But it could also be that a pitch on equity can be a USP, and that can differentiate you from somebody else whose product is about high market scale rather than about equitable distribution.
Elsa, what is your hot take? Go.
We're building for broad populations, which is necessary, but by doing so, we're ignoring the narrow. We're ignoring personalization, we're ignoring precision, and we are painting broad stroke pictures and saying that because something applies to everyone, that applies to everyone. But it's knowing that risk, for example, which we like to apply to every single person, is not universal. We all have different risk profiles, and so we have to start targeting the people on the sides, the people on the fringes.
And what's the incentive for them to do it? It's really hard. People who are building are trying to prioritize hundreds of things. So what's in it for them? How do they win?
That's such a hard question. I think you have to build for accuracy and safety. Is what do you prioritize? Unfortunately, the market has prioritized revenue and has prioritized the only outcome to be revenue. And when you start looking at other value additions, which are safety, evidence-based, trust, and looking at those as incentives, then you can actually start driving out how that even eventually reaches revenue.
We've solved equity. There it is. Boom. Okay, so we've just done a session on health equity and inclusion, and we've got person who made this all happen.
Yes.
Give us your hot take.
My hot take is co-design. Co-design, co-design.
What do you mean by co-design? Aren't people doing it by saying that they're patient-centric?
No, they're not. I really think people should be trying extra hard to co-design properly. For example, if you are creating a service in mental health, you need to speak to the psychiatrists and you need to pilot with the psychiatrists, with the patients that they're seeing. So co-design really involves taking all the people in that whole patient journey and bringing them all in when you're designing, rather than just picking a few people off social media.
Super. Heena Patel, hot take, go.
Hi, I'm Heena, and let me tell you about today's hot take. We've just done an amazing session on identifying inequalities in mature digital health systems. How do we not know that these exist? And why are we not doing anything about it? Today we learned from individuals in Spain, Portugal, Ireland, and now what we're seeing is that across the board, everyone is facing the same problem. So the hot take is this: fix the problem.
And what do people need to do to fix it?
What they need to do is they need to be honest with themselves. They need to be able to look at how that system is being built. They need to be able to say to themselves, listen, you know what? There are designs and models and workflows that are not aligning, and that is keeping our patients lost. What I would say is go find them. We need to find them. They're out there. They need us.
Be proactive. I love it.
Absolutely.
Nice. Thank you. Andreia, give us your hot take.
My name is Andreia. I work with the digital processes, and my hot take is exactly what are we trying to solve for in health? Are we trying to solve for profit, or are we trying to save money, or are we trying to save lives? Because when we actually choose correctly the outcomes and what we want to solve for, we can actually measure it correctly. So it's important that governments, healthcare providers, clinics, we define what we want to solve for and who we want to help and who we are not helping. What are we missing out here?
And what do you think that health systems are missing on who they prioritize? Because they're prioritizing often for the whole, and some people might think underserved communities are more difficult. We'll figure out as we go along. What would you say to that?
Well, again, that is how you measure impact. How are they measuring the impact of this type of population being missed out? The impact that it has on an economy, or the impact that it has on families and how families show up for work and for each other in the community. So the funding part should be talked about. We often talk a little bit on a dreaming perspective about people and how we're doing to save lives, but bringing the tough conversation that it's on money and how do we fund all of this research and also the output of choosing to miss certain parts of population out. How do we see things in the medium and long term? What is the costs?
So
for our
longer term thinking and a wider definition of value.
Yeah.
Society.
Other definition of value, love it.
Awesome.